and welcome to another episode of Keeping London Healthy. I'm Dr. Mario Elia. Today we'll be joined by Dr. Sonja Reichert. She is a local physician with expertise in diabetes and obesity to chat about diabetes. So she'll be giving us some helpful pointers, as well as talking about an exciting study that she's leading that some patients who are watching the show today may actually be eligible for. So looking forward to speaking to Dr. Reichert after this message. All right, welcome back. Again, we're pleased to be joined today by Dr. Sonja Reichert. Dr. Reichert is an expert in diabetes and obesity here in London. She's an associate professor in the Department of Family Medicine at Western, and she works at St. Joseph's Healthcare in the Primary Care Diabetes Support Program. She's also a researcher at Lawson Health Research Institute and affiliated with the Center for Studies in Family Medicine. And she also is the Dr. Brian W. Gilbert Chair in Primary Health Care Research at Western. So we're really pleased to have you join us today, Dr. Reichert. Thanks for joining us.
Oh, thank you very much for having me on. I'm so excited.
As I was mentioning to you before, this is amazingly the first episode we've done on diabetes, which you would think would be one of the first topics we would have covered, but with COVID and we've hit some other interesting topics that we're finally getting around to diabetes. So I guess we'll start from the absolute basics. And we're going to be focusing on type 2 diabetes today, just for patients out there who have type 1. The things we're going to be talking about today won't be entirely relevant to you. But for patients with type 2 diabetes, can you tell us a little bit about, what is type 2 diabetes?
Well, first off, I'm so happy that this topic is being covered today, because even though we were going through tremendous times with COVID, diabetes and other chronic diseases didn't take time off. And so we're finding that people really had a hard time during the pandemic. They may have lost their family physicians or weren't able to keep up with regular screening. So now is really the time to get back on track, revisit things. So I'm really happy we're able to have this chance to regroup today. And to answer your question, so what is type 2 diabetes? Well, in its simplest form, diabetes is high blood sugars that's either caused by the body not making enough insulin or the body not being able to use the insulin that it makes efficiently. So this results then in high blood sugars in the circulatory system. Now, the story is much more complicated than that, and there is the famous ominous octet, which was described in the literature, which basically explains that there is in fact 8 different organs and body systems that are involved with type 2 diabetes beyond the pancreas that's responsible for making insulin. So organs involved include the brain, the kidneys, the muscle, of course, the beta cells in the pancreas, but also the alpha cells and the liver. So in fact, it can touch on and impact almost every organ in the body.
So when someone's first diagnosed with diabetes, so they see their doctor, and whether it's they had symptoms or whether it was just picked up on routine screening that they had, patients told you have diabetes. Patient that you see for the first time that's diagnosed, what are some of the things that you would kind of review with that patient, and what are some things that patient really should know?
And even to back it up before then, I would really encourage people to be screened and to identify if they either have pre-diabetes or diabetes, because the tricky thing is diabetes is often a very silent disease. It's very sneaky. So you may be walking around with type 2 diabetes and not even know it. So if you have certain high risk factors that may predispose you to diabetes, anything from family history, your genetics, if you have it run in your family, perhaps age, it's a higher risk as we get older, if you're carrying a little extra weight, if you're of a certain ethnic group, we know that certain ethnic groups have higher rates of diabetes. I'll say, make sure you get screened and find out if you have diabetes or not have diabetes. And then if you are diagnosed at that point, I really see it as an opportunity for the future. So there's so much to learn with diabetes, so much to know, but the main thing is with good blood sugars. If we have good blood sugars, hopefully none of the complications that we worry about with type 2 diabetes, hopefully they won't happen. So super important to get on top of it quickly, get it under control, and keep it in control.
Absolutely. And the screening, we've noticed, at least anecdotally in my own practice, through the last 2 3 years, I've been finding the number of patients that we've been picking up with diabetes has gone up. I would say compared to years past, and whether that's inactivity, change in diet related to the pandemic, but certainly we're picking up a lot more diabetes, I would say. So definitely, if someone's one of those high risk categories that you mentioned, speaking to the doc, speaking to your doctor, and really up to yearly in some patients with risk factors that we're doing this kind of screening. And one group that kind of gets missed, anyone with gestational diabetes. You know, you had pregnancy and sugars went back to control, and you forget about it. But really, those patients too should be having a blood test done yearly to make sure that's not that type 2 diabetes isn't creeping up. Let's talk a bit about nutrition. I know that's probably one of the first things that we chat about when patient comes in with a new diagnosis, and there's a lot of kind of confusion to patients in terms of what's the best diet. Should I be doing this diet or this diet? This person went on this diet and found their blood sugars were great. What I know it's a bit complicated, and you could probably go on for hours about this. But Cole's notes, opinions around diet and diabetes.
Oh, this could be a whole separate segment just in of itself. And I think that's what makes it so tricky because there is so much darn information about there. It makes it really hard for people to navigate. And oftentimes, the shiny newest diet or way of eating, pattern of eating. I always say diet is a four-letter word. Sort of pattern of eating and food choices is a better way to look at it. It can get confusing. Should I do this? Should I do that? You get so many different opinions. So I'd say, bottom line, speak to your healthcare professional to go through the pros and cons. But as an overarching concept, the sort of the basics is that with type 2 diabetes, blood sugars go up when we consume carbohydrates. So we often think of diabetes, if we eat too much sugar, it can raise our blood sugars. But sugar is what we call a carbohydrate. And carbohydrates, again, they can be so sneaky. They can be found in so many different foods that we often don't think about. It's not just the classic chocolate bar or Coke, that we think of sugar laden rich foods. But carbohydrates are in our grain products. So in bread, they can even be found in sauces like ketchup. And really, it's important we start looking at our labels and understanding where these carbohydrates are found. So the overarching principle is that if we eat too many carbohydrates with type 2 diabetes, blood sugars go up. So the main idea is to limit or try to control those carbohydrates. So that's one main principle. The second main principle when we're thinking about food intake is that weight or excess weight can raise that insulin resistance that I talked about at the beginning. So the more weight we carry, especially if we're carrying it around our midsection or abdomen, can raise our insulin resistance, making it hard for the insulin we already have to be working. So if we're able to reduce our weight, if that is one of our challenges, that also helps with blood sugar control in type 2 diabetes. So now we sort of have two main principles, perhaps fewer carbohydrates and some weight reduction. Now, how we get there, that's where it becomes complicated. And the way I think of it is like with medicines that we prescribe in our office, Dr. Elia, we have lots of options. So how do we pick a medicine? Well, we talk to the person, we figure out what works with their lives, what they like to do, what their financial situation is like. There's so many variables that go into when we choose a medicine. medicine. And I think that choosing a pattern of eating should be approached the same way. So there's lots of options. So intermittent fasting is one that's brilliant for some people, where they sort of restrict the time in which they eat. So this is great for people who graze all day, who are munching and eating little bits of food all day long. It really helps to control the amount that they're eating into a pre-specified distinct time. For other people, it makes them incredibly hangry and angry and grumpy, and some may even find their blood sugars are higher in the morning if they've done a long fast. So again, one size does not fit all. And I think that's the number one thing I'm a proponent of is type 2 diabetes is going to be different in every single person. I like to explain the story. I have two sisters that often come to the same appointment, and they're using the Libre monitor, one thing I'll be talking about later, and they'll eat exactly the same food and have two different numbers. Well, that's because they probably have different insulin resistance levels. They have different ways of processing the food they're eating. So it comes down to some trial and error, working with your healthcare professional, and it comes down to comorbidities. So if heart disease is a concern, then perhaps the Mediterranean diet is the way to go. If you have high blood pressure, there's the DASH diet that focuses on salt reduction. So again, it's finding food as medicine, finding the right pattern of eating that A, you like, that B, gets you the results you want, and that C is something you can maintain and do for the rest of your life. We're not into fads, into gimmicks. I really want people to find ways of eating that they can sustain for the rest of their lives.
Extraordinarily helpful answer. And my next question was going to be around exercise, and I suspect the messaging is going to be similar in terms of what exercise is best with someone with diabetes, and I suspect the answer will be something along the lines of what they can start with safely, what they're motivated to continue, what they enjoy doing, and what's sustainable. Would that be fair to say in terms of your recommendation?
So exercise is medicine just as much as food is medicine and as the medicines you're actually taking. And the dose and the prescription for exercise based on the current Diabetes Canada guidelines is 150 minutes of moderately intense aerobic activity, broken up or divided amongst most days of the week, plus 2 days of resistance or muscle strength training. So to break that down, aerobic exercise is, of course, anything that gets our heart rate up. Moderate intensity will be different for me versus for you. So that's something to figure out. But, and we don't want to do it all 150 minutes on the weekend or on one session. That can be, is not, that'd be taking all of our medicines just once a week or once a month. So we want to scatter it amongst the week. The other trick is, like you said, to find something you enjoy doing that you can do. And if 150 minutes is too much, start where you're at now. The bottom line, again, the most important thing is to just get active. So we are not meant to be sitting all the time. So I even speak to my patients if they're unable to engage in sort of formal exercise. We think of the gym or going to, those sorts of things. Walking is one of the best activities, and even just counting your steps during the day and seeing where you're at and striving for a goal that you'd like to reach. The ideal is sort of 8,000 to 10,000 steps. But again, if you're not there yet, no worries. Start where you're at. And just the important thing is to stick with it, keep going, and something is better than nothing.
I know in the last few years, certainly some patients with a diagnosis of diabetes maybe haven't been seeing their healthcare professionals as often. And maybe they're not being reached out to as often by those healthcare professionals because of circumstances. I know it's going to be individualized based on the patient, but is there a frequency at which patients should be seen for their diabetes, and how often should the average patient be getting blood work done? Again, obviously individualized, but any general principles there?
I'm a big proponent of people taking control of their own health We call that self-management, and part of that is knowing your numbers. So for most people, for the average person, we check what we call their hemoglobin A1C every 3 months. So that's something we encourage people to get done every 3 months. If diabetes is really well controlled, we sometimes stretch it out to every 6 months. But other things to keep track of on those every 3 to 6 month visits that you have with your physician or healthcare provider. You also want to know how your kidney function is doing. That's often missed or not covered. So we look at both how the kidneys are filtering or functioning, but also if there's protein in the urine. And the protein, I call it the check engine light of your kidneys. It's often an early alarm that your kidneys may be under stress from diabetes. And of course, we also want to make sure people have routine eye exams. So every 1 to 2 years, which is covered by the Ontario government. And also feet. We can't forget our feet. The typical is sort of every 6 to 12 months to have your feet looked at. But if you do have a history of wounds or ulcers, it may be as often as every 3 months that your healthcare provider looks at your feet, which of course doesn't mean you shouldn't be looking at your feet and checking and taking good care of them in between those appointments as well.
I know that you contributed to a chapter in the National Diabetes Guidelines around remission of diabetes. So I know that's a topic that's that you're quite passionate about. Can you tell us a bit about, what are options for remission of diabetes? Essentially, kind of long-term remission. What are your thoughts around that?
I'm so glad we're able to touch on this. This is so exciting. But before we dive into that topic, I also wanted to add to the, know your numbers, know what's going on. So A1C, we're striving usually for a target of 7%. For some individuals, again, it's individualized. It may be 6.5, it may be as high as 8.5. But also don't forget about your heart health. You should be having an ECG done every 2 to 3 years for screening, and of course mention if you have any symptoms that concern you to your healthcare provider. So very important. I wanted to add that in. Yeah. But for diabetes remission, oh my goodness, I'm so glad Canada finally has crafted an official statement on the topic. We already know from our European colleagues and our American colleagues, they have made statements, but Canada has officially announced that diabetes remission is an option and is a possibility. And I think this is such a time of hope for patients with type 2 diabetes, in that it tells a different story. We're often told, I know I was taught in medical school, that diabetes only gets worse over time, and that once you're on insulin, it's probably forever. But we're now learning that we can go back and forth with our health. You may be diagnosed with diabetes, and while you never are able to cure it, you always have type 2 diabetes, you are able to maybe put it into remission.
And I know that one of the options that we have beyond nutrition and exercise changes is bariatric surgery. I know we've talked about that in a previous episode. What's been your experience with patients with diabetes, with obesity, with sugars that are kind of tricky to control, in terms of the effectiveness of bariatric surgery for getting them into remission?
The definition of remission is an A1C of 6% on no medications for more than 3 to 6 months. And again, it'll still be important, even if you are in remission, to get your A1C checked at least every 6 months or so, because again, diabetes could come back. Now, the way to go into remission, in the guidelines, there's 2 major ways that we discovered can help with achieving remission. So the number one thing is to try and lose weight. So again, that 15% of body weight loss, around 15 kilograms on average, is where we see people are often able to go into remission. So again, it's not for everyone. It might not be a goal for everyone, because I mentioned being off off all medicines. So some of the medicines we take for type 2 diabetes are actually important for our heart or for our kidneys, or they're the medicines that have actually allowed us to lose weight in the first place. So again, speak to your healthcare provider. If diabetes remission is even a good goal for you, perhaps excellent blood sugar control on the least amount of medicine, but you need some of those medicines, is the better goal for you. So that's very important. But if, let's say, you are interested in remission, there is bariatric surgery, which we do know can have a huge impact on people's lives in terms of their health-related quality of life and impact on certain conditions that are impacted by obesity. So that could be diabetes, arthritis, many conditions. Again, not one size fits all. It might not be appropriate for everyone, but we also have some really great medicines that can help with weight loss as well, that can lower those blood sugar numbers and help reduce weight as well.
We're going to take a quick break, and when we come back, we'll be talking about a really exciting study that you're leading and giving some information around that. So we'll be back right after this message. Welcome back. Again, we're being joined by Dr. Sonja Reichert, and really excited to ask you about a study that I know you're leading here in London called the Liberate study. So I'll give you a chance just to tell us a little bit about what the study involves and how patients potentially could get involved.
I've spoken a lot about, what is diabetes? How can we help it? Now we're getting into some of the actionable things. So the Liberate study, the essence of it came from our clinical work here in the clinic, in that we realized that if patients with type 2 diabetes really see and understand their blood sugar numbers, they're better able to act on them and try to improve them with food and activity as medicine. But if you're not able to see them, which was often the case with the older glucose testing technology we had, you're missing a bunch of data. So this newer technology that we have is really game-changing in helping to open patients' eyes in understanding their blood sugar. And the purpose of Liberate is basically to tie all that data and all that information together for participants over a 6-month period, where they will have access to the Libre flash glucose monitoring technology. But it's also coupled with coaching, so that human teaching of, okay, now we see all these blood sugars. Well, let's learn about them. Let's reflect on them. Let's turn that information into action.
Patients who are interested in this, how can they, who's eligible? How do they go about getting hold of you guys?
Perfect. Yeah. So we're looking for 92 people from London. And so we're well underway with recruitment, and we're looking for people who have never used a Libre monitor or the Libre glucose sensing technology, who have an A1C above 8%, and people who have internet and are a little smartphone and technology savvy, because the program itself is mostly run virtually in a group format. So we meet every 2 weeks for 3 months, where we have that coaching and we talk about the blood sugars. We see the information from the meter. We learn more about how to manage diabetes, really putting it all together. And then we have booster sessions for the last 3 months of the 6-month program, where we sort of prepare people to be on their own and live and confidently self-manage their diabetes.
Exciting to have this study done, right here in London. And I know for a lot of patients with diabetes, it's been trickier to obtain diabetes education, I think, over the last couple of years with some of the changes over at St. Joe's. So again, if you're a patient who meets those criteria, and we'll include the links on the bottom of the screen here for patients to get a hold of. And yeah, it's really exciting. And I know you guys are actively recruiting, and looking for that target number. So hopefully patients find it helpful.
We have an amazing team who's created Liberate, the programming, the education, an amazing team that I work with here at St. Joe's that are helping to run this program. So we would love to have people from London join. If you think you're eligible but aren't sure, get a hold of us. We have a website, www.liberateDiabetes.ca, and we can help you figure out if you're eligible. And if you have a family physician, we can work with them as well.
Thanks so much for joining us today. So much helpful advice, and again, the study looking very exciting, and hopefully patients can sign up if they're eligible.
Well, thank you for having me. And the number one overall aim is to keep people healthy and happy, and self-managing their chronic conditions. Thank you.
Thanks again to Dr. Reichert for all of her helpful info on diabetes. And again, a reminder to all patients watching who may be eligible for the Liberate study to check out the information and the links we provided. So until next time, stay healthy.